Clinton with the Heart of Medicine, and today is June 5th, sorry. And we're continuing to get ready for this internal medicine certification examination before moving on to cardiology. So this is day number 18 straight without any days of rest, making these videos for you guys. And the reason for these videos are, of course, for you to be able to listen while you wash the dishes, drive your car, etc., etc. If you're preparing for the internal medicine certification examination, that's going to help you. If you're just preparing maybe for step 2 CK, step 3, probably going to help because a whole lot of it is internal medicine. And if you're just interested in medicine, we got some nice pearls for you. So as I go through these question banks, that's the thing I do with these. I'm doing with these videos. So without further ado, let's go into the action here. We're going to focus on the clinical pearls. So I'm not just going to tell you the educational objective, because if that was the case, I wouldn't have a reason to make a video. So I'm also going to add a little more information and also my brain storm in here. And yeah, it's trying to help everyone out here. So this first patient, well, this question was basically asking which of the following procedures is most likely to improve outcomes in this patient. So if you just go to the options here and don't even see the don't even read the question, you can see that some things make sense, some things don't make sense. So if you see daily arterial blood gas testing, like why, right? That's probably not an indication in most things out there. Daily chemistry profile, no, that's not a reason. Daily complete blood count. So remember that there's also high value care. So this is a sort of a combination between high value care and also how to prevent infections, or yeah, it seems like a high value care question. In summary, they're showing you how to utilize resources adequately. Just because most hospitals check a blood count and a metabolic panel every single day on admitted hospitalized patients, that doesn't mean that's the correct course of action, right? So if you don't have a clear and compelling indication, you shouldn't be checking this daily. Of course, if you're following an anemic patient that is bleeding out, or you are suspecting this patient is bleeding or will rebleed, yes, it makes sense to be following the blood count. But if not, you have to have a reasoning behind it. So the answer here was daily assessment of the need for a central venous catheter. Remember that central venous catheter is a frequent source of infections. So if you don't need it, you better take it out because you don't want to have a CLABSI. CLABSI stands for central line associated bloodstream infection. Well, that's in the case it was generating a bacteremia. So it makes sense. Most of your patients having a central line probably should be in the ICU, and probably most of them will actually be able to discontinue the central line before getting out of the ICU, unless they have a prolonged course of antibiotics or something clear. But always, any patient you have with a central line or any catheter, make sure you have a day count on it, so you just don't forget about it for days on end. Okay, so let's see what else can we add here. Enteral nutrition is important, but it's usually recommended within 48 hours of admission, or 48 hours since being in the ICU. Basically, if your patient is critically ill, let's see, but hemodynamically stable, yes, within 48 hours. But if your patient is hemodynamically unstable, you shouldn't be doing enteral route because it's risky for the gut. You can generate bowel ischemia. So now let's move on to the next question over here. This second question is important because it's acid-base. Acid-base will always be asked in the test. So our main question here is, what's the reason this patient is having an acid-base disturbance? So remember, always with acid-base, whenever you see acid-base questions, don't even read the whole thing. Just if you see a pH and they're asking you about different types of things generated in different acid-base arrangements, just go to the pH. That will tell you your primary disturbance or primary derangement, and then you go see the other things such as the bicarb, the PCO2, and etc. So start off seeing the pH at 7.48. You know that's alkalosis. Now you have to determine, is this metabolic or is this respiratory? So here you have the bicarbonates. It's 34, so it is 10 above normal, meaning that it is metabolic alkalosis. So you just go to the options here and see which one of these produces metabolic alkalosis. And of these, well, seizure disorder has nothing to do with that. Diuretic misuse, some diuretics can generate alkalosis, some can generate acidosis. It depends on which diuretic you're using. So that's not gonna, most of your diuretics will generate metabolic alkalosis. Just a couple will generate acidosis. That's gonna be the carbonic anhydrase inhibitors, and maybe, not sure if mannitol, but most of them are metabolic alkalosis. Okay, so they also give you urine chloride. So when I saw this question, I actually got it correct, but I wasn't sure of what the cutoff for urine chloride was or not. And this is very important, because when you have metabolic alkalosis, you will further define what's going on looking at the urine chloride. So if the urine chloride is basically high, let's see, if the urine chloride is high, it means that it's going to be responsive to fluids, I think. If the chloride is low, it's going to be non-responsive to IV fluids. So let's just go to the table. So differential diagnosis, here you have the metabolic alkalosis with a bicarb above 24. Of course, that's going to be metabolic alkalosis. Now you look at the urine chloride. Urine chloride cutoff is going to be 20. If it's less than 20, it's low urine chloride. So, sorry, when the urine chloride is low, it is saline responsive. So let's make sense of it. Basically, if you have contraction alkalosis, right? So you're basically disappearing everything from your system, all these electrolytes. Your kidneys, if they're working, they should hold on to chloride. So that probably explains why chloride is low if you're vomiting, right? If you're vomiting, you're trying to hold on to chloride, and the chloride in the urine will be low. and that means that you're probably going to be saline responsive. So options with low urine chloride are vomiting, NG aspiration, nasogastric aspiration. That's why anyone that has an NG tube should never be on constant suction. It should be low intermittent suction, and even that can potentially generate the contraction alkalosis. So watch out with that. And another one is diuretic overuse. So there's a caveat here, because if you have been using the diuretic chronically for days or weeks, the urine chloride will be low, because basically you have depleted your body of the chloride, and that's why it's low. But if you just use the urine, the diuretic, it can actually give you, instead of a low urine chloride, it can give you a high urine chloride. Okay. Um, why? Because you just use the diuretic and it's just making you pee right there and then more chloride. So that's just a caveat there. Now we're moving on to the other side, which is the high urine chloride. If it is above 20 milliequivalents per liter, now you have to consider the volume status of the patient. If the patient is hypovolemic and is still wasting a lot of chloride in the urine, those kidneys are bad. Something's bad with the kidneys. So your options here are Bartter and Gitelman syndrome. If your patient is hypervolemic, okay, so now hypervolemia, but you're still having a lot of urine chloride, you might actually have excess mineralocorticoid activity. So meaning that aldosterone is basically acting too much in excess. So it's holding on to too much sodium, and sodium holds on, of course, to water, and sodium and chloride also follows those. And eventually you have been holding on to so much sodium and chloride, I guess, that you will be peeing out higher amounts of chloride on average. So your urinary chloride will be higher. Other things that can generate mineralocorticoid excess, not only hyperaldosteronism. Remember that Cushing disease with cortisol. Cortisol has a little bit of mineralocorticoid activity, so it can also generate this. And ectopic ACTH production can also induce this. So ACTH will also stimulate the production of corticosteroids in the adrenal gland. So the group with the high urinary chloride is usually known as saline unresponsive. And why is it going to be unresponsive? So if you have one of these syndromes that are just wasting chloride, Bartter and Gitelman, you can give them saline, but it's just going to be peed out. If you have excess mineralocorticoid activity and the patient is hypervolemic, doesn't make sense to give more saline. You can worsen it off, right? So that's it with this question. We already went through all that. And yeah, that's the main clinical pearl there. Now, oh, why was it surreptitious? So this patient was having surreptitious vomiting. Okay. So the only one I wasn't sure about here, generating metabolic alkalosis, was maybe ecstasy intoxication, because this patient seemed to be hypotensive, volume down, and decreased. Most electrolytes were down. So I thought to myself, maybe ecstasy, right? Maybe this patient is sweating everything and volume depleted, which makes sense, but it doesn't, it's not known to cause metabolic alkalosis. And surreptitious vomiting is. So we already went through that, and we already saw that on the chloride level. But let's just read why it wasn't ecstasy. So ecstasy can cause tachycardia and anxiety and hyponatremia. Metabolic alkalosis and hypokalemia are not expected. And now we're moving on to the next question over here. So this other question is important, because they're asking us, in a patient with heart failure with reduced ejection fraction that is already on GDMT, or guideline directed medical therapy, as you can see here, carvedilol, sacubitril, valsartan, furosemide, and spironolactone, basically, which of the following EKG findings will change the patient's heart failure management? So you don't have to read much here. You can just read the question, okay? What can change heart failure management? You can just see the options, and there's some things that don't make any sense. QRS axis shift, like when will you change your management just because of the QRS average vector? You won't, right? So you cross that out. Precordial Q waves. So many times you see that on most of your EKGs. You just order an EKG, a random EKG, and you get the software read that says Q waves in inferior leads rule out, anterior rule out. What is it? Old myocardial infarction not able to be ruled out, something like that. So Q waves, pathologic Q waves, yes, in the adequate clinical context, you can think, okay, this patient had a remote infarct or myocardial infarction, or something acute could potentially be going on, but no, it's not going to change your heart failure management. So increased QTC interval, okay, that's something that would make sense, because if you have an increased QTC interval and you are using azithromycin or something like that, maybe the answer would be change azithromycin to doxycycline, right? That would not be QTC prolonging, for example. But this is a heart failure question, so that's not the answer. Prolonged QRS duration, yes, that makes sense, because when you're treating heart failure with reduced ejection fraction, you look at the QRS duration. If it lasts, if it's pretty prolonged, mainly if the patient has complete left bundle branch block, you have to consider cardiac resynchronization therapy. You can even consider it with a right bundle branch block, but the QRS has to be very prolonged, and we're going to see the indications here. So indications for cardiac resynchronization therapy would be a left ventricular ejection fraction less than or equal to 35% and sinus rhythm with one of the following. So here you have a QRS above 150 milliseconds and New York, basically functional class 3 or 4 on optimal medical therapy. That's a recommendation grade 1A. If the QRS duration is between 120 and 150 and functional class is 3 or 4, yeah, you could consider it. If you have a functional class 1 or 2 on optimal medical therapy and already undergoing pacemaker or ICD implantation with anticipated frequent ventricular pacing, well, why not do the CRT? And another group indication is those patients with a LVEF, which would be lower of 30% or less, with a QRS more than or equal to 150 milliseconds, with left bundle branch block and a functional class. Now it would be more normal, basically asymptomatic or mildly symptomatic on optimal medical therapy. Okay, so those are your indications for cardiac arrest synchronization therapy, and it depends on the QRS duration. Okay, so that's it for this one. Let's go on to the next question. Okay. Oh, this one was one of my favorite for this question block. So this one I didn't get correct because I didn't think that maybe if these two things were going at the same time. So it's interesting because this is a 72-year-old male, which is having severe tearing pain in the anterior and posterior areas of the chest for the last 2 hours. Okay, so that should point you towards aortic dissection. But look at this, which is pretty interesting. So yes, the patient is hypotensive, a little bit tachycardic, but there's additional findings such as jugular veins are distended when the patient is sitting. Heart sounds are distant and no murmurs are heard on cardiac auscultation. So, and they also gave me an EKG, and here's the EKG, which there's some alternating QRS complexes. You see, there's like alternating. This QRS amplitude is different than this one and different from this one. So I saw this as electrical alternance. So this took me to me thinking there are two things going on. It seems like there's aortic dissection and there's maybe cardiac tamponade. And I just thought something's wrong. So I thought that the test maker was probably wanting us to choose between one and another. That's why I chose bedside transthoracic echo followed by pericardiocentesis, because I just said, no, probably this patient just has cardiac tamponade. So let's do a bedside echo and pericardiocentesis. Well, this was a more real life sort of question because actually, if the patient has type A aortic dissection, which would be the ascending aorta, you can have compromise of the valve area. So that can generate aortic regurgitation. But one of those complications of the dissection can be that the dissection can go into basically or affect the pericardium. And you can have an aortic rupture into the pericardium and have cardiac tamponade. So how would you diagnose that? Well, we usually think of CT angiogram if the patient is stable. The patient is unstable. Usually it was transesophageal echocardiogram, but at least the ones who wrote this question said that transesophageal echo needs some sedation and that you could do a quick transthoracic echo and that it maybe would give you enough clues. And I think that reasoning is okay. I do think that transesophageal echo can still be done in an emergent situation if the right people are there. But I do understand the main thing with this question is you want to do a bedside transthoracic echo followed by transfer to the operating room. Why don't you do a pericardiocentesis if the patient has tamponade? Because if you have a rupture of the aorta into the pericardial sac, if you do a pericardiocentesis, you're going to have trouble because you might generate a complication that's not written here, but it's called pericardial decompression syndrome, which basically it's going to generate a whole lot of hemodynamic instability because you're going to continue to remove fluid and fluid from the pericardial sac. You're not fixing the problem. You're just exacerbating the problem and generating sort of a vacuum there that will be even worse for the patient. So we already talked about the main points here. And let's see. That's it for this question, basically. Why take the patient to the operating room? Because of course, this type A dissection is for the operating room. Type B dissection is more conservative or percutaneous management, which would be a TVAR, right? And that's it with this question. Let's go on to the next one. So the next question, this is an interesting one, and I'm not sure if this question is updated as it should be because this patient is an immigrant from Brazil, and the patient does have a systolic murmur, apical impulse is displaced, and there's an echocardiogram showing ejection fraction 35%, normal coronary arteries, there's left ventricular apical aneurysm and left ventricular what else? And EKG showing right bundle branch block. So all these findings, of course, are telling you heart failure with reduced ejection fraction, immigrant from Brazil with a specific pattern, apical aneurysm, and they're asking you which of these microorganisms can cause it. So yes, Trypanosoma cruzi generating Chagas disease will be the right answer. I have no doubt about it. It's the only one that can generate the dilated cardiomyopathy, and it is usually in this pattern. But the problem here, what I don't like with this question or answer, is that it says that chronic Chagas cardiomyopathy is the leading cause of dilated cardiomyopathy in Central and South America. That is definitely not correct. That is incorrect because I come from Central America. And I was a cardiology resident in Costa Rica, and most of our patients with dilated cardiomyopathy definitely didn't have Chagas, and it wasn't due to Chagas. So times have changed. Now the chronic comorbidities, of course, are way more prevalent in these nations, including, of course, Costa Rica. And most of the cases of dilated cardiomyopathy in Central America, I'd say today, 2020s or 21st century, would be due to these chronic conditions, chronic untreated hypertension, chronic, uncontrolled diabetes, chronic hyperlipidemia, et cetera, right? So I don't think it's also the case for South America anymore. I do think you always have to think of Chagas in Central and South, but it's not going to be so prevalent as mentioned here. But okay, let's go on to See what other things we have. Blastomyces. I didn't remember much about blastomyces. All you have to maybe remember is, yes, it mainly affects the lungs and it can affect other organs as well. And what else do we have for blastomyces? Blastomycosis is a systemic granulomatosis infection, usually involving the lungs, that causes acute or chronic pneumonia. It can also involve extrapulmonary sites, including skin, bone, and genitourinary tract. That's about it for blastomycosis. Maybe Leishmania donovani is causes visceral leishmaniasis, also known as CALASAR, and it's characterized by insidious onset of progression of fever, malaise, weight loss, and splenomegaly. Of course, Lyme generating the atrioventricular conduction block, and dengue generating the fever and maybe hemorrhagic fever if severe. And that's it with that question. This other question is a patient, 75-year-old woman. She has all these clinical findings for temporal arteritis and or giant cell arteritis. And yes, she has the jaw pain with chewing. She has, well, she's had fatigue, but she has blurred vision, all those things. ESR is very high. It's 88. So, of course, the patient was started on prednisone with resolution of headaches and significant improvement of symptoms. Her biopsy initially did not show evidence of giant cell arteritis, only atherosclerosis. So what is the best following course of action? And the answer was to obtain a biopsy of the other temporal artery. So that's the clinical pearl. If you have all the things aligned for temporal arteritis, you treat it as such, even if the biopsy is negative, because the risk of not treating it is way too high. So you continue the steroids that sometimes may go up to even a year, and you don't taper off the steroids, and you get a biopsy on the other side, because with temporal arteritis, up to 40% of that initial biopsy will be negative. So that's the main information you have from here. Presence of, okay, there's several criteria, of course. Usually it happens when patients are above age 50, ESR is elevated, the jaw pain, etc. Okay, so now we're going on to the next question. So, oh, this one, I'm not sure if I got it correct, but basically this patient was non-ambulatory in the nursing home, had fever, productive cough of yellow sputum, was started on azithromycin for pneumonia, and was sweating a lot over the past 5 days, and now has this rash you're seeing here. This looks like a little, very little, not vesicles, right? Because it looks like they are maybe vesicles. So I just answered this question with what I thought was correct. I know keratosis pilaris does not look like that. It looks like little bumps, or as if your hair follicles are just like erected, and that happens when you go out in the cold. You'll see the hair follicles like that. That's how keratosis pilaris looks, and nothing looked like that. So miliaria was the right answer. There's miliaria crystallina, miliaria profunda, miliaria pustulosa, and rubra. So I'm guessing this one was, yeah, miliaria or heat rash, which is due to blockage of the eccrine sweat ducts in the setting of increased heat or humidity. It is most common in newborns and young children, but it can also occur in bedridden adults with fever, increased sweating, or tight-fitting clothing. So let's see, miliaria rubra. This is another one. Interesting. Rubra means red, so that's why you see a similar thing, just red. And this one I would have said miliaria pustulosa because it looked like little pustules, like yellow, yeah, not transparent. Let's see which one it was. It doesn't specify. But we already talked about what miliaria is. Let's see. Uh, Miliaria pustulosa is similar to miliaria rubra, but with more significant pustules on an erythematous base. Miliaria profunda is due to ductal obstruction in the dermis and presents with asymptomatic flesh-colored papules or pustules. Treatment includes sweat reduction with cool baths, compresses, or light and loose clothing. So we never knew which type of miliaria this was. Uh, Okay, so maybe this was Miliaria crystallina, or crystalline. Maybe I'm not sure. Maybe not the best picture. And now let's see keratosis pilaris. Just so you, oh yeah, see, completely different. As if every hair follicle was there, like very not only like erected, but yeah, like angry, right? So now let's go on to the next question. Oh, this one, they show you this hand, and this thing has been going on for what else? For a while, I think. A week of pain and discoloration. This is not Raynaud's phenomenon or Raynaud's syndrome, so you rule that out. And the patient is a smoker, has several, yeah, things to consider. He is an intravenous drug user. He has this thing. What else? Let me see if I got it correct. But we'll see complete blood count, nothing quite special. But he did have a reduced hypocomplementemia, C3 and C4, elevated rheumatoid factor, and elevated ANA. And it was hepatitis C infection. So I think it was cryoglobulinemia. Remember, hepatitis C starts with a C, same as cryoglobulinemia. So this was essential mixed type 2 cryoglobulinemia. And in essential mixed cryoglobulinemia, it's associated with hepatitis C and more percent with palpable purpura, arthralgias, membranoproliferative glomerulonephritis, low serum complement, cutaneous vasculitis, and neuropathy. The vasculitis may cause skin necrosis and gangrene in some patients. Treatment of hepatitis C may reduce cryoglobulins and improve skin symptoms. So I'll leave it at that. That's going to be the main thing. And yeah, that's it. Let's go on to the next one. Question 10 now? No, we skipped one. So this patient, oh, I didn't get this one correct. So this patient was feeling like a foreign body in the throat, had a diagnosis of 2 centimeter non-metastatic papillary thyroid cancer 3 years ago, was treated with a near total thyroidectomy followed by radioactive iodine. Okay, so they didn't take out all the thyroid. And that's about it. So which of the following is the best initial step in managing this patient? Calcitonin is for medullary carcinoma of the thyroid, so you ruled that out. Neck ultrasound, no, I wasn't sure. I thought that we didn't have to test any longer. I thought this symptoms were normal, but no, you did. You should have done TSH, free T4, and thyroglobulin level. So follow-up surveillance of papillary thyroid cancer. So here we were at year 3, so this is year 2 to 20. You do serum TSH, free T4, thyroglobulin annually. Neck ultrasound every 1 to 3 years or less frequently in low-risk patients. Diagnostic radioiodine scan for abnormalities. And that's about it for this question. Thyroglobulin is secreted by most differentiated thyroid cancers and it is a useful marker of recurrent or persistent cancer following thyroidectomy and radioactive iodine ablation. Elevated thyroglobulin requires further testing with neck ultrasound and diagnostic radioiodine scan. So we're about to finish, and this one I had no idea how I got it wrong. You see that I was able to rule out most of them, and this patient needed vitamin supplementation. I was thinking discontinue methotrexate. So what was happening here? I had no idea, to be honest, what was happening here. It had recent diagnosis of rheumatoid arthritis, no fevers. She was treated with naproxen and methotrexate for 6 weeks with improvement of joint symptoms. What else is going on? Oh, the patient was showing several shallow ulcers on the buccal mucosa and hard palate, as well as mild pharyngeal erythema. No enlarged lymph nodes are palpated. No skin rashes. And what else was found here? Neutrophils were normal. Rest was normal. A little bit of anemia, which was the best next step to supplement with vitamins. So, not sure why. Let's see why. Common toxicities of methotrexate include fever, stomatitis, macular rash, gastrointestinal disturbances, and hematologic abnormalities. Okay, so my reason wasn't that bad. Maybe we have to reduce or get methotrexate out of the picture. But no, we had to supplement. So stomatitis and megaloblastic anemia can be prevented by folic acid supplementation. So that's what you wanted to do. You wanted to treat the side effect or the depletion of folic acid from methotrexate with folic acid, and that was good enough for this patient. Let's see why we shouldn't have discontinued the methotrexate. So let's see. Um, let's see. Sorry. All patients taking methotrexate should receive folic acid at 1 milligram per day with dose increases to 5 milligrams per day based on symptoms. Folic acid usually improves stomatitis. Patient without symptom improvement after folic acid supplementation may need to discontinue methotrexate. That's it. Now, next question is a 58-year-old male with progressive generalized weakness. What's going on here? Let's just remember. Okay. Okay, so this patient was basically having cirrhosis and a cirrhotic patient, and there's no mention of his endoscopy. There's no mention of his stomach or no endoscopy. Remember that any patient with cirrhosis should have an upper endoscopy because that's one of the way you can determine the portal hypertension possibility. So if you find varices, okay, it's an indication of portal hypertension, and it's also important for you to have that baseline to know what the risk for this patient is. So let's see what the explanation said. So guidelines for variceal prophylaxis in portal hypertension. Well, how do you know that? With an upper EGD. So patients newly diagnosed with cirrhosis require an esophagogastroduodenoscopy to document varices and assess the risk for variceal hemorrhage. First-line prophylaxis typically consists of non-selective beta blockers. That's the main point with this question. I'll leave it at that. And let's go on to the next one. This other question, obtain serum TSH levels. Okay, this patient is a patient that has several different alterations, and they're asking us what can be affecting the labs. So this is a patient that has high blood pressure, that has weight gain, that has hypertension, weight gain, mildly obese, glucose is fine, AST, ALT are fine. Total cholesterol is elevated, LDL is a little elevated. So what do you do there? You just have to check if this patient was having hypothyroidism instead of just assuming that this was bad diet or diet or anything else, right? So it could have been a secondary cause of dyslipidemia. So here you have diabetes or hypothyroidism can cause secondary dyslipidemia. So you're going to check a TSH for the thyroid and an A1C for the diabetes. Okay, and that's it for that question. Let's go on to the next one. We're almost finished. This other patient is an interesting patient, 80-year-old patient with a whole lot of comorbidities. So this patient has hypertension, type 2 diabetes, prior ischemic stroke with residual right-sided hemiparesis, and he was having acute cholecystitis, and a pericholecystic fluid is present and multiple gallstones. So they're asking us, oh, he also has idiopathic pulmonary fibrosis and is on continuous oxygen. So this patient has a whole lot of things. So they're basically telling us, hey, this patient has a whole lot of things. Right now is even hypotension due to this cholecystitis. And how are you going to treat the patient? So the patient was already on pip tazo, so that's fine. You don't have to add vancomycin. Is ERCP wouldn't make sense because the bile ducts are normal. So then I was between these three options: laparoscopic cholecystectomy, percutaneous cholecystectomy, or ursodesoxycholic acid therapy. I thought this patient was like so bad or such a high mortality that I was just trying to be the least invasive possible. But the answer was percutaneous cholecystectomy. Most patients with cholecystitis should undergo early laparoscopic cholecystectomy as it is associated with reduced morbidity and mortality. Patients who are at high risk for surgery and fail to improve with conservative treatment, such as fluids, analgesics, empiric antibiotics, can benefit from percutaneous cholecystectomy. So, okay, what's the main difference here? Um, if the patient, we already talked about that. Yeah, so what I'm not understanding or wrapping my brain around is what exactly would percutaneous cholecystectomy look like? Percutaneous cholecystectomy. Let's see it. Images. Oh, okay. Cholecystectomy. No, that is cholecystostomy. Cholecystectomy. I think it was, what did it, what was the option? Cholecystostomy, man. I didn't read the question adequately. If I would have seen cholecystostomy, I would have marked that because yes, that's the one that just decompresses the gallbladder, putting in the tube inside the gallbladder, and basically it is a temporizing measure in patients that are like this, so high risk. But I thought it said cholecystectomy, and I'm like, what? What does that mean? So yeah, read your questions with all the attention necessary. And the last question here is we're talking about a medication toxicity, which I got wrong. I wasn't sure what was going on. So this patient had some kidney injury and had a living-related donor kidney transplant a year ago for membranoproliferative glomerulonephritis. The patient was feeling well, and the patient was on all the immunosuppressive medications, was compliant with it, but all of a sudden blood pressure started elevating. It revealed mild Cushingoid features, and the abdomen was soft, non-tender. Creatinine was worsening, uric acid was elevated, and urinalysis was normal. So they're asking you what's going on here, and the answer was that you were having a medication toxicity. Let's see what it was. Calcineurin inhibitors such as cyclosporin, tacrolimus can cause nephrotoxicity that presents with declining glomerular filtration rates and metabolic abnormalities. Toxicity is dose dependent. Drugs metabolized by cytochrome P450 3A4 can increase toxicity. So which one was that? Clopidogrel or other medical issues include hypertension, diet controlled by type 2 diabetes. Current medications include tacrolimus, prednisone, meclofelonate, mofetil, lisinopril, and amlodipine, as well as fluconazole for recurrent vaginal candidiasis. So that's the key there. The addition of fluconazole was the cytochrome P450 inhibitor. So these other medications were not metabolizing, increasing their levels and increasing the risk for toxicity. And that's why the calcineurin inhibitors, such as tacrolimus here, generated the problems with the kidney medication toxicity. So that's about it. So here you have common interactions of tacrolimus and cyclosporin. So of course, this is basically telling you which medications are cytochrome P450 inhibitors, such as these, and which are cytochrome P450 inducers, such as these below. So you can pause the video and yeah, go through them. And that's it. And yeah, time to go share with family a moment. And that's it. See you in the next one. Comments, feedback, opinions. Let's go. Peace.